Okay, so thank you very much, Yinting, and hello to everybody. So I'm very happy to present my and to share my experience on ENT management of PCD patient. First, I want to show my Do you know if Yinting, if
yes.
Okay, that's good. My disclosure of conflicts of interest. So, as you know, primary ciliary dyskinesia is a rare respiratory disease, which is an autosomic recessive disease for the most patients. And it's characterized by a defect and in the function as well as structure of the cilia. And clinically, the expression is named the sino-pulmonary syndrome. We can add auto-sino, as you will see. And we can see on this CT scan bronchiectasis. On the otoscopic examination, otitis media with effusion. On the CT scan, the chronic rhinosinusitis. And in half of the patient, we can observe situs inversus, and in a various proportion of patients, fertility impairment. So the impact of rhinosinusitis in general is a decreasing of quality of life, which will impact on well-being, will induce depression in patient, especially in patient with olfaction impairment. It impacts on work and productivity, on security, especially with patients that have nasal congestion that will induce apneic syndrome. And in case of anosmia, there are some home accidents that can be due to the absence of olfaction in case of leak of gas. Nasal obstruction induces snoring, and it can worsen sleep apnea. And the patients that have post-nasal discharge are often saying that they cough a lot, especially during sleep. And as I said, anosmia is a source of taste impairment, and it can induce bad eating habits, especially with a lot of salts and sugar. The hearing loss is impacting everyday life as well. In children, it can decrease speech acquisition, and it induces isolation. There are studies that have reported that patients with hearing loss has less job opportunities, and it impacts negatively on the evolution of some degenerative disease. So when we go back to PCD, in France, there are 37 centers and 2 ENT centers, reference centers for PCD. As you can see, in France, the 2 ENT centers are very close because they are in the suburb of Paris. The first one is in Créteil, which is a reference center. And in Bicêtre, in my hospital, we are a competence center for rare respiratory disease, especially PCD. And there are also other reference centers, pediatric reference centers in Paris, in the center of Paris. So in my competence center, we have several collaboration with multidisciplinary collaboration. We have an outpatient clinic for patients that are referred for PCD, for suspicion of PCD. We see an average of 4 patients per week, and the patient have several tests, including CT scan, nasal nitric oxide measurement, lung function test, and complete ENT exam with endoscopy and micro-otoscopy. And they have systematic hearing evaluation, and we perform nasal biopsy for electronic microscopy. We can sample blood for genetics and sample secretion for microbiology. In my center, the main patients are referred by pulmonologists, and we make an average of 10 new PCD diagnoses per year. We have an active cohort of an average of 80 patients. So you know that for PCD diagnosis, the history is very important to proceed for more thorough examinations, and the family history, the lung history, and naturally the ear and nose history. So why upper airways are so important in PCD? Because it's, as you've seen, a major criteria for PCD diagnosis, and it's always involved in pathology. The upper airways impacts air conditioning, impacts audition. The ENT disease has a major impact on quality of life, and there's no strong evidence, but some publication suggested that it could impact lung disease, and for the optimal management of PCD patient, upper airways must be considered. When we saw that, when I said that, there is another problem that the ENT symptoms and clinical studies are very underreported, and the cohort are very small, often single center, and there is a lack of standardization of the symptoms or outcomes when evaluating ENT in PCD patients. So as you've seen, Myrona has made a review of literature that showed that there are very heterogeneous results on the incidence and prevalence of sinusitis and otitis in PCD. So what are the ENT presentation of PCD in children? First is the respiratory history, as you know. In the newborns with PCD, we can see a majority of neonatal respiratory distress, which is very different in adults. There are chronic and productive cough, and the children has recurrent and very severe bronchitis and sometimes pneumonia. And it's important to notice that in the first years of life, at least in France, the bronchitis can be absent because we prescribe a lot of antibiotics for ENT infection. So the absence of severe pulmonary history doesn't eliminate the diagnosis of PCD in young children. When we look at the ear disease, usually it's the major presentation of ENT disease in PCD, with in the ENT history the multiple acute otitis media and otitis media with effusion that induce a lot of antibiotic prescription, and the prevalence of otitis media with effusion is very variously reported between 17 and 100% of patients. And in the history, we usually record multiple myringotomies and ventilation tubes insertion. And when you discuss with the parents, they usually report a very abundant ear discharge, especially after ventilation tube insertion. Usually, the natural history of otitis media with effusion shows improvement according to the age of the children. I show you this interesting study, which look at the evolution of hearing threshold in children that have the majority of normal otoscopy, and near half of the children with OME with a conservative treatment. It means that there was no ventilation tube insertion. The audition improved naturally, as you see, with the different subgroups of age of patient, with a hearing threshold that was very high in the first years of life and improve. But you can see that it did not normalize even at during adolescence. It's the same study, another study which shows the same results, with the increasing of the percentage of children with normal hearing according to age of the children. Concerning nasal disease, there are very few studies in children, but when, in my experience, and I think you have noticed that when you ask the parents, they very oftenly report nasal discharge and nasal. There was a strong encumberment of secretion in the nose of children with PCD. And there is one study that reported severe smell disorders of children, and it may be interesting to look for more thoroughly this kind of smell disorder and the evolution with age. So now I will turn to the ENT presentation in adults. So we based we make a study on 64 adults with PCD in Paris, with all the specialists that are working with me. So it's a population of 37 years median age. And the sex ratio was a majority of male, and you can see that 1/3 of patients have consanguinity in their parents, and the FEV1 was an average of 72 plus or minus 24%. What is interesting in this study, it shows that that 22% of the PCD patients were smokers or former smokers, and there was inflammatory comorbidity in more than 1/3 of the patient, especially allergy. In their respiratory history, we, as I said, we reported less neonatal respiratory distress compared to the pediatrics cohort. It's usually because the adults cannot remember or have not been aware of neonatal respiratory distress. In the adult cohort, you can see that all the patients had bronchitis symptoms, and the bronchiectasis was between the 1/3 and 1% of adult patients. So if you can see the video, I will show you a typical ENT exam in an adult patient. This is the otoscopy, and this patient was a 34-year-old man with a CDCC39 mutation and 100% IDA defect, and with bronchiectasis and situs inversus. You can see here the inferior turbinate of the left nasal fossa with the pseudocystic aspect of the mucosa. And this is the middle turbinate with the strings of mucus that are very sticky, and other abundant mucus here in the olfactory cleft. On the other side of the nose, I will show you very interesting results. It's a very obstructive hypertrophy of the inferior turbinate, as you can see here. The head of the inferior turbinate is just inflammatory, but the rest is very hypertrophic and is cause of nasal obstruction of the patient. So let's go back to the study, and as you can see, the ear disease is very frequent in adults, and you can see that hearing loss is present in more than half of the patients, and was the main symptoms that was reported. And we had also otorrhea and tinnitus and pain in the ear. Concerning the audiogram, I will show you another ancillary study just after, and you can see that 1/3 of the patient had normal audition, but in half of the patient there was hearing loss that was either conductive or mixed. It means that it was conductive and sensorineural as well. And in 15 patients of the patient, that was only sensorineural hearing defect. Concerning the otoscopy, the exams show an abnormal eardrum in more than half of the patient, and the main pathology was otitis media with effusion, as you can see here. So we can say that ear disease improved during childhood, but remains during adulthood. So I will show you a typical ear CT scan of an adult. So you can see here that this is vertebra. Here is the rhinopharynx, is the mandibula, and I will show you on the video. Here is the mastoid, and usually it's with a lot of air. And in the, as you can see on the CT scan, the cells of the mastoid are completely closed, and there is a fibrosis of the cells, as you can see here. And this is the middle here that is completely occupied by seromucus secretions. And your eardrum, the eardrum is retracted. You will see here. Here is the eardrum here that is retracted, and the ossicles are normal. So as I was saying, we made another prospective study that compared the CT scan, the imaging presentation of the ears in 17 PCD patients that were compared with a control group of patients that had a complete PCD workup that was negative. So they were all referred for bronchiectasis, and the control group, in the control group, we eliminated the diagnosis of PCD. So you can see that in the PCD group, nearly 60% of the patients have a history of otitis media. And in more than 70% of the patients, there was an abnormal otoscopy with abnormal eardrums. And as I was saying in the last study, the major presentation was otitis media with effusion. And concerning the hearing loss, you can see that the conduction and mixed hearing loss was the majority presentation of hearing loss in the patient, and it concerned half of the patient. It's very important to notice that because it will impact the management of hearing loss in children and adults. So as I was showing you on the CT scan, we found a great majority of patients with abnormal CT scan. And as I was showing you on the video, there was fibrosis of the mastoid cells. You see in the control patient, mastoid are very well aeration of the cells, and here you can see that the cells are completely fibrosed. You can see as well tympanosclerosis. It means that there are thickening of the eardrum that is retracted. In the normal patient, the eardrum are nearly non-observable. And as you can see, the eardrum is very thick, and you can see that there are fibrosis in the middle ear. Here you can see the middle ear, a complete filling of the middle ear, as you can see here, and abnormal ossicles that here you can see the stapes that is very thick compared to the stapes of the control. So now let's go to the nasal disease of adults of the first study I presented you. The adults have a lot of rhinologic symptoms. The major symptoms are rhinorrhea and nasal obstruction, but they have facial pain and hyperreactivity as well. And olfactory defect have been reported in the study in more than half of the patient. In nearly all the patients, the endoscopy of the nose was abnormal with turbinate hypertrophy, as you can see here, which is present in at least half of the patients, and in 1/3 there are strings of mucus and pus that are very sticky in the nose, and in 1/3 of the patient we observe nasal polyps. There was no correlation between the nasal disease and the PCD type and the lung function of the patient. Wow. So I will show you now a very typical sinus CT scan in adult PCD patient. So here you can see these are the teeth of the maxillary. This is the nose. This is the mandible. And when we go up, you can see there are in the maxillary sinuses opacities that can be complete or partial. Here you can see the inferior turbinates that are very hypertrophic and obstructive. And when we go up, you can see here the ethmoid, which is partially or completely obstructed, and which is very specific of PC patient is the hypoplasia of the sphenoid sinuses, as you can see here, and the aplasia, there's no frontal sinuses. And we can see this kind of presentation in more than 70 patients with PCD. So, in the other study of 17 PCD confirmed patients compared to control group, you can see that nasal polyps are observed in nearly half of the patient. The SNOT-22, which is quality of life specific for rhinosinusitis, we can see that the score is very high. The maximum is 110, and the most the score, the highest is the score, the most important impact on quality of life. You can see that hypo or aplasia of the sinus were observed in nearly 90% of the patients. And as I was saying, there are sinus opacities in the majority of patients, and defect of sinus development that are diversely reported. We found that it was more than 80% in our cohort. When we look at the microbiology of the middle meatus of patients, we identified bacteria in the great majority of patients, and in the bacteria was same compared to the sputum in PCD patient, with the majority of patients with Haemophilus, Pneumococcus, and Pseudomonas. There was a positive correlation between the nasal bacterial load and age, but not with the lung function test. So we also made a correlation between the nasal function test, it means rhinomanometry, and the lung function test, and we show no correlation between the two. So now I will go to the management of upper airways in PCD. So the basics of the ENT management, it's very important to be a multidisciplinary management involving ENT, but pulmonologists, physiotherapists, and geneticists, and all of the specialists that are working on PCD patients. The therapeutic education is very, very important in this disease, as well as other rare diseases. And the patient must be informed that surgery is a rare treatment, and the most part of the treatment is medical with medication. As I said at the beginning of my talk, there is low evidence and no guidelines regarding ENT management in PCD patients. But we can have, however, objective of treatment. It firstly to improve quality of life, and we can use questionnaires that can evaluate the quality of life of patient. I was saying that it's not 22, that which is a rhinosinusitis specific quality of life questionnaire, but there is also the quality of life PCD specific for PCD questionnaire. We have to improve symptoms, and for that we can use the ENT module of Follow PCD form that we publish with Myrona. We have to improve examination, so using endoscopy and micro-otoscopy to reduce infection, and we have to check very regularly the microbiology of the middle meatus to reduce the polyp size. So we can use the score endoscopy, the endoscopic polyp score, and the CT scan opacity score. And concerning the ear disease, the audiogram is very important to follow in order to evaluate the evolution of hearing in patients. So as I was saying, we publish paper on the Follow PCD data form, which is a very interesting instrument because it's standardized, so very interesting for the follow of patient and to compare patient across different centers. The information are collected at the first consultation, but are used during the routine follow-up. There are a lot of information that are recorded in this form concerning the history, the examination, the test, the treatments, and there are different modules, and there is a module for ENT disease, and there are also questionnaire that are auto questionnaire for the patient and the caregivers. So as you can see, there are 9 modules here, and there are a module for the upper airways and ear that we use in the everyday practice. So now let's go to the management of ear disease in PCD. And as I was saying, there's very few surgical management, but hearing aids is one of the major management of ear disease in this rare disease. The hearing aids can be the classical air conduction hearing aid, but it can also be very interesting in this disease to use the bone conduction hearing aid. I will show you there are two types of bone conduction hearing aid, the non-invasive and invasive. Concerning the medication, the ear rinsing for a local asepsia, but as well as antibiotics and corticosteroid drops in case of ear discharge with a purulent secretion. Surgery can be indicated in some cases, and we have to use local rather than general anesthesia in order to be the less aggressive for the lungs. As I was saying, the bone conduction hearing aids are very interesting in these patients because, as you saw in my presentation, the majority of the hearing loss in this disease is transmission, conductive hearing loss. So when you use the bone conduction, you squeeze the air hearing, so you have an excellent results on hearing. Especially in case of ear discharge, in this case, the air conduction classical hearing aids are impossible to use. So as you can see, the higher is the air-bone gap, the better is the results of a bone conduction hearing aids. So as I was saying, there's two types of bone conduction hearing aids. First is the non-invasive bone conduction. We have two types of bone conduction, non-invasive bone conduction hearing aids: the headband, as you can see here, or the adhesive bone conduction with the micro and the transducer that is in contact with the mastoid, and the vibration is directly transmitted to the inner ear, and it squeezes the outer ear and the middle ear. You can see here a clinical case of a young lady with a headband, and it's very interesting, especially because she, as you can see, she has hair that are not that are impossible to use other types of bone conduction hearing aid. And you can see the audiogram. This is the air conduction, the bone conduction, and this is the result with the hearing aids. And you can see that the child who is hearing at this level at baseline can hear nearly normally with the bone conduction hearing aid, and it improves as well the speech audiometry. It means that it improves the understanding of words repetition. The other types of bone conduction hearing aids are the invasive ones. The principle of this type of hearing aids is to put an implant in the temporal bone. It can be inserted under local or general anesthesia, and on this implant you plug a processor that include a macro and a vibrator that will transmit the sound in the bone, in the temporal bone, and then in the inner ear. So it could be very impressive when you see this. This is a patient I saw 10 days ago with a bone conduction hearing aid. You can see this is the implant here. This is the implant that you can see here, and you plug the processor, and you have, as you can see here on the audiogram, an excellent result with a very bad hearing at baseline, and with the heads, you can see that the hearing is very significantly improved with the device. Now let's turn to the management of the nasal disease in PCD. So as usual, it's mostly based on medication with nasal rinsing, with ISO or hypertonic saline, with high volume and low pressure using, as you can see, several devices that can be found in the pharmacy. We can also prescribe oral antibiotics. The best is to prescribe after a microbiology sampling. We can use low-dose microlyze in long-term treatment, just like in bronchiectasis. Nasal corticosteroids can be useful if the patient has nasal polyps. And nebulization is rarely used, but it can be useful in some difficult to treat sinusitis. Concerning surgery, sinus surgery is only performed under general anesthesia, so we have to pay a lot of attention in the preparation of general anesthesia, which is a very sorry, I have to plug my computer. So we have to prepare the general anesthesia because it can be. I have several patients that develop pneumonia after a general anesthesia, so it's very important to prepare the patient with a physiotherapist and sometimes sometimes antibiotics. So the nasal rinsing. This is a video that a colleague in Belgium shared with me. Here, the nasal rinsing in the neonatal period. The principle is always the same. You have to wash the upper nostril in order to have as you can see here, the serum that goes through the nostril and go out the lower nostril. Here in the child, older child, the principle is the same with the lota. This is the lota, and we ask the child to breathe through the mouth in order to close the velum, and you can see that the serum is going up to down, and then it's very very useful for the blowing of the secretion. There are some studies that suggested that nasal sinus surgery can be interesting in order to reduce the sinus bacterial reservoir. I show you a study that been made in Denmark with only 8 PCD patients that had ethmoidectomy and antibiotics after surgery. And the outcome was the comparison of pre-post operative sputum microbiology. In this study, you can see that only 2 patients who had Pseudomonas before surgery were negative after surgery, but the follow-up is only 1 year after the surgery, and we have no study that characterize the bacteriology, the microbiology of the bronchus at long term after sinus surgery. We made a retrospective study on patient. We compare PCD patients that were operated versus PCD patients that were not operated on the sinuses. And we had 15 years follow-up, median follow-up. and we did not find any difference concerning the quality of life score, CT scan, nasal microbiology, and lung function between the two groups of patients. But the most interesting results of this study was that in the patients, the PCD patient that had surgery in their history, had a later PCD diagnosis that was made at the medium of 33 years, compared to the non-operated patient that had a median diagnostic age at 23 years. So there are a lot of remaining questions on ENT PCD, ENT presentation in PCD. We don't know if there are markers of severity. We have to evaluate the long-term evolution of the disease, and we have to be more clearer on the impact of ENT disease on the lungs, and what are the efficacy of the different therapy, and we have to define more outcomes and standardized outcomes for characterizing ENT disease in a PCD patient. And this is a study we have performed, and we will publish in a very rapidly. So as you probably know, Yinting, Myrana are conducting a prospective cohort of PCD patients with special attention to ENT presentation. As you can see, the different centers that are participating in the study, and to date we have more than nearly 500 patients that have been included, and we are currently studying the ENT, otologic, and sinus presentation of the patients. So now I just want to thank all the specialists that are working with me on PCD and the different research unit I am a member of. And I would like to thank as well the PCD patient support group, which is very implicated in the disease, and I am very pleased to work with them and to organize the yearly reunion meeting of the association. So thank you very much.
Thank you very much, Jean-François, for this excellent presentation on ENT management in PCD. We now start the Q&A. The first question comes from Mirona. She said, "Thank you for this excellent talk, Jean-François. I was wondering about hearing aids. What is your experience with acceptance from the patients? We have had many participants in the cohort saying that they were recommended aids, but do not really wear them. Do you have any advice regarding better adherence?"
Yeah, when I discuss with other ENTs across Europe, one major problem issue with hearing aids is the reimbursement. For example, I remember I discussed with the Spain ENT team that is working on PCD, and in Spain there is a very low reimbursement, so they have to perform mostly insertion of ventilation tubes and surgery. But in France we're very lucky because since 1 year and a half, the hearing aids are for the first the law, there is a law that allow 100% reimbursement of hearing aids in France. So the financial issue is not an issue anymore. So as I was saying, in PCD patients, the air conduction hearing aids are usually very difficult to adapt, because the patients have most of the patients have conduction hearing loss. It means that they have otitis media with effusion, so they have to put the volume very high with this kind of hearing aids. And in case of hearing discharge, hearing aids are not useful because the external auditory canal is completely obstructed with nasal secretion. That's the reason why the bone conduction hearing aids is a really very interesting device for the PCD patient. And as I was showing you, the headbands are very interesting in children, because usually children have hearing loss that is not that will improve during age. So it can be a transitory hearing aid, and you can stop the hearing aid when the hearing is improving, and you can turn into a invasive bone conduction device in case of persistence of hearing loss in adolescence or adulthood.
Thank you. Our next question is from Tugba. Thank you for your nice presentation. Are these hearing aids only for conducting hearing loss, or are they also used for sensory neural loss? And the rate of sensory neural hearing loss was high in your PCD patients. What was the reason for this?
There are two questions. So the first one is in case of sensory neural hearing loss, we cannot recover for sensory neural hearing loss. So it's very important to wear hearing aids, either air conduction or bone conduction. But as I was showing you in my presentation, you can see my slides. This patient I showed you, he has a mixed hearing loss. As you can see, this is the hearing loss from the inner ear. So there is a sensory neural hearing loss, but there is also a conduction hearing loss. So the patient is able to hear at this level, but actually he only hears at this level because there is the otitis media with effusion that is impairing the conduction. So when you put the bone conduction aids, we can improve the audition, but we never can improve. The best improvement we can have is the level of the sensory neural hearing loss, as you can see here. So you cannot hear best than that. And the second question was, I can't remember.
Second question was, and the rate of sensory neural hearing loss was high in your PCD patients. What was the reason for this?
Oh, it is very interesting, because we were very surprised to find that there is nearly 20% of PCD patients with sensory hearing loss, and we have several hypotheses for that. The first one is that there's a lot of antibiotic prescription in France during childhood, and it can be a reason for, especially with macrolides, that is an ototoxic antibiotic. But as well, when we study a patient with otitis media with effusion, not only in PCD disease, we can observe that the chronic inflammation of the middle ear can have a bad impact on the ciliary cells of the inner ear. So it can be a reason for sensory neural hearing loss as well.
Thank you very much, Jean-François. I think this question was on many people's minds with the mixed hearing loss. Now, next question coming from me.
Oh.
You mentioned that patients do underreport their symptoms. Now, what is actually then the tipping point? What problems do they have that they actually get referred to you?
You mean they're mainly referred for PCD diagnosis, actually. So when they are referred for PCD diagnosis, we have a special evaluation of ENT disease. So they see that, and I explain to them that the ENT follow-up is very important, as well as the chest follow-up. Then they go back, they come back to the center because we have made the diagnosis and we have explained the disease, and we have a special place in their follow-up. But I also have some patients that are referred from other PCD centers for specific ENT management, and usually in the adults it's the sinus and the sinus disease rather than the ear disease. And I'm very lucky because in the department we also have department of otology, very specialized in otology problem. So I usually share the patient with my colleagues that are very expert in hearing rehabilitation.
Thank you. Our next question is from Susie. What do you recommend for patients with fluctuating hearing who do fairly well in hearing tests, but struggle frequently in everyday situations to hear adequately?
There's no specific recommendation. I think that during exacerbation, they usually have hearing impairment. That's the reason why we try to treat very quickly the patient with exacerbation. Sometimes we have to make myringostomies when in case of acute otitis media. But usually we try to treat the patient with antibiotics and sometimes with nebulizations, and we are using a device that can push some air in the auditive auditive tube. And we tried. I didn't show you because we only tried another kind of surgery in 3 patients. It means it's a balloon that it is inserted in the nose and through the nose into the auditive tube in order to dilate the auditive tube. But the results are very transient. It's not lasting a lot. So we have improvement, but it never lasts more than 3 months. So I choose not to present you this kind of treatment, but we tried that.
Excellent, thank you. The next question is from Rachel. She asks, for patients with nasal drainage or discharge, at what do you start the nasal rinses and at what frequency?
We start at early as possible, and I recommend in children at least 100 milliliter of saline. Isotonic is best. The children are more as you can say, they are supporting. No, they are more. They tolerate well the isotonic compared to the hypertonic. And in the adults, I recommend 1 bottle, an entire bottle, as I showed you. This kind of bottles. 1 bottle in the morning and 1 bottle in the evening, twice a day. In both nostril. It means that half of the bottle on the left, half of the bottle on the right, in the morning and in the evening. And I showed you this device. I think it can be found on the online shops. It's a device that has several, you can see several types of rinsing with, we can have with this device rinsing very hard and other very thin. And some patients are really pleased with that, but it's very expensive. So usually we only recommend the bottles.
Thank you. Our next question is from Lionel Benchimol. Thank you very much for this nice presentation. What type of treatment do you recommend in case of persistent otorrhea? If the patient has VT, should we remove them? Thank you very much.
Thank you, Lionel. So in case of discharge, it's local drops, and the priority is local drops. And it can be corticosteroids and mixed with antibiotics. We usually make oftenly microbiology sampling. And in case of ventilation tubes, if the discharge is very, very, very important and the patient cannot support that, we can remove. But in case of when we remove the ventilation tube, the problem is that if the eardrum is closing, you have otitis media with effusion. So there are some patients that prefer having ear discharge and good hearing, and rather than have no discharge and otitis media with effusion that would impair hearing. So that's why the bone conduction hearing aid could be interesting, because we don't put any ventilation tube. Usually the patient does not have any ear discharge and they can hear well.
Thanks a lot. The next question is from Nicole. She asks, she says, first of all, thank you so much for this amazing presentation. Some PCD centers unfortunately don't have ENT integrated as part of the multidisciplinary treatment. Would an annual review with SNOT-22 score be a good screen to refer knowing patients are compliant with nasal rinses and sprays and severe symptoms persist? If so, what would be your advice for the cutoff for this?
The cutoff for what?
A cutoff for a SNOT-22 annual score to refer them to an ENT.
I think that the SNOT-22 is not the only parameter to look for, but as you know, in the SNOT-22 there are some symptoms that are directly related to the nasal disease, but there are also items related to the well-being, to the sleep. So that's the reason why SNOT-22 is not enough to refer patient. But in case of strong nasal obstruction, I think we can have a good treatment for reducing the volume of inferior turbinate. I have 14 patients in whom I have made turbinate reduction. It does not meet the turbinate. I never removed inferior turbinate. It is very important information. But I reduced the volume, and in this case, the patient are more easier to perform the nasal rinsing, because the nasal rinsing can penetrate more profoundly in the nose in case of a small turbinate, and usually there is less secretion that are staying in the nose. So in case of strong nasal obstruction, even isolated nasal obstruction could be very interesting to refer the patient to the ENT.
Thank you. So I have a question. On one of your earlier slides that you mentioned otitis media with effusion is greater in the summer. What's the reason for this?
In fact, actually, it's a characteristic that is very interesting when the patient are referred for PCD suspicion in my department. Usually, otitis media with effusion usually resolve during summer in non-PCD patient. And what is can ring a bell is the persistence of otitis media with effusion even during summer in a patient with bronchitis and other symptoms of chronic infection. During summer, usually chronic infection improves in children.
Thank you very much. The next question is from Birgit. She says, thank you for your great presentation. What do you think about dupilumab for nasal polyps as an alternative to surgery?
Yeah, it's an excellent question because dupilumab is very efficient in nasal polyp disease in non-PCD patients. We are very pleased to prescribe dupilumab since 1.5 years. ENTs are authorized to prescribe dupilumab in type 2 inflammatory nasal polyp disease. In PCD patients, we are currently trying to characterize a type of inflammation in nasal polyps because, as you know, there is a lot of infection in PCD patients. So we are probably in front of Th1 disease in PCD patients with a lot of neutrophils. So I have one patient that had dupilumab that have been prescribed for severe asthma. He's a PCD patient with severe asthma that have been prescribed the dupilumab, but he has no polyps. So I cannot. I think if we try to prescribe dupilumab in PCD patients, we have to make biopsy of the polyps first in order to look for eosinophils and to look for Th2 inflammation, because this is a major criteria for efficacy of dupilumab. But it can be very interesting to try.
Thank you. So I can't see any more questions in the chat, but I just want to say thank you for your really excellent presentation, and I really enjoyed how visual it was, and thank you so much for this really vivid discussion.
Thank you. Thank you very much for your attention and your invitation. It's a pleasure for me.